Good morning, and welcome to you all from our Mount Sinai's Cath Lab. I'm here, I'm Ramesh Sharma, your moderator, along with Dr. Karthik Gujja.
Good morning.
We welcome you to another excellent and very interesting live peripheral broadcast for our CCC live cases. We have a couple things to discuss as always before we get started. We're looking forward to filling up and spamming your inboxes with all of our invitations and flyers regarding our New York Endovascular Summit coming up this October 6th, 7th, and 8th. The 6th being our Fellows course and the 7th and 8th being the dedicated Endovascular Summit agenda, both with aortic, venous, and peripheral vascular cases and live live case discussions. We'll talk more about that towards the end of the case today. Today, we are very excited to have Dr. Prakash Krishnan and Dr. Vishal Kapoor, taking us through another very, very challenging, very complex case. And Dr. Krishnan, we pass it off to you.
Thank you. Thanks again, and welcome everyone to the Cath Lab. And we're very excited today to have you for this wonderful case. First of all, we'd like to acknowledge our endovascular fellows. Luke Murphy, today is his last day. Great job. We really appreciate everything that you've done for us. It was a phenomenal year.
Thank you. Thank you so
And
much.
we'd like to acknowledge Twinkle Singh, who I know is virtually watching us. She's already moved on to her new job. So Twinkle, we miss you, and I'm glad you're well. So having said that, we've got this exciting new case that I think is shows some it's going to show some challenges, on how to cross and how to deal with vessel mismatch. So without further ado, I'm going to introduce our team. Obviously, in front of me is Vishal Kapoor. Behind me is Ray Lascano, Luke Murphy to my right. We've got Jen Curiel, and we've got Liz Holton, and we've got Damien here to support us through this case. So Luke, without further ado, why don't you get started?
Sure. So we can put up the PowerPoint. So for our case today, we have a wonderful 68-year-old woman, has risk factors including hypertension, hyperlipidemia, has prior interventions on her carotid, and known peripheral arterial disease, has had multiple interventions both at Sinai and outside. In clinic, she admits to severe bilateral claudication with less than a half a block walking before she has to stop, and even progressing in the last few weeks to rest pain at night, putting her at a grade of Rutherford 4. It's worse in the left leg than the right. She is on appropriate medications, unable to tolerate cilostazol due to GI upset. Now on exam has Doppler pulses bilaterally and low ABIs. She had actually a recent intervention to the left iliac, after which she felt better but is still having symptoms. And at that time, we'll go through the angiogram in more detail here, but at that time had demonstrated SFA and popliteal disease that we'll go through right now.
I mean, this is a patient who's, one of our patients who's classically, starts off with a claudicant and then, has multiple areas of stenosis, multi-level disease with single vessel runoff, and then starts to become an ischemic rest pain type patient. I mean, half block claudication by anyone would pretty much, assume that it's going to be rest pain. So in this particular case, we called it rest pain and CLTI because of her symptomatology. But you'll see anatomically she does have multi-level disease, which would explain her problems. Vishal, can you go over the anatomy?
Yeah, so if you can see the angiogram right here, we took a iliac with femoral shots as well. So the two iliac stents that were put in look patent. Otherwise, the iliac itself doesn't have much disease. But once you start focusing on the left CFA, SFA, which I'm going to show you better pictures, you can see that's where the disease process starts. Patient has a significant distal left CFA, you can call it ostial SFA disease. There's a stent in the mid SFA region, which looks pretty much patent, some mild diffuse ISR there. But the real problem is, like PK was talking about, the reason for the symptoms is the left popliteal, which is completely occluded, and it reconstitutes pretty much at the AT.
But also, it's important angiographically. If you look at that angiogram, let's look at it and analyze it. So she's a lady who's had common femoral endarterectomy, and now you can see here she's got diffuse profunda disease. If you look at the collateralization, it's really coming off the distal SFA into the anterior tibial.
Yeah.
She does not have any robust genicular collaterals coming off the profunda, giving rise to the the tarsal what is it called, the the pop and the tibial supplying the gastrocnemius. So the majority of this is going to be coming from your SFA to tibial collaterals off that distal geniculate, which is very, very important angiographically. This also, like Vishal was talking about, you can see that she has single vessel to the foot. So it also, you have to, as an interventionalist, when you look at this kind of lesion, you got to be very, very careful on how you approach this. And what we decided to do in this case is to go ahead and get tibial and above access. And believe me, all of you guys are doing tibial access beautifully. So we just got it offline. It's no big deal. So we used ultrasound guided. Dr. Kapoor and Dr. Murphy got it offline. And now we've got a wire in the tibial. But the logic is why you do what you do. So if you see here, as your I'll tell you when to stop it. Go play that runoff. Yeah, right there. That's good. That's good. You couldn't even play that shot, the last shot that Luke had.
Yep.
Yeah. So you can see here. Nope. Next one. So you can see here that that particular collateral comes off exactly where the stump of the popliteal occlusion is. So while you're mucking with that, you can effectively shut down this anterior tibial artery, which is a single vessel runoff to the foot, and convert this to patient who is having rest pain to just acute limb, which becomes a little problem. Now you've got these speckled collaterals and geniculars coming off the profunda, but the profunda is not the diffuse thing, and it's important angiographically to notice this. Second, as you go through, now what we did was we didn't put a sheath in the leg. We just put a command wire, and I'm just going to show you angiographically. We just put a command wire at the level of the AT just to have access into the AT if that should happen. Second is the clinical presentation. Was it acute, Vishal? I mean, this is your patient?
Yeah, so it's worse than clinical presentation. She's been a smoker, a vascular path. So last 6 weeks, the symptoms have really gone down bad. She's an active worker who takes care of her mom and works at the same time. So her symptoms barely like half a block to rest pain. So definitely in the last 6 weeks, the symptoms have definitely worsened to a point of debilitation. Right.
So she clearly has some sort of thrombotic component possibly. And it definitely does make sense that here, track it, Ray, a little bit. So here, Ray and I are just going to, so we're just going with a woolly wire, try to get into this SFA. Push it down, Ray. Okay, good. And then let's see, okay, that's in the profunda. That's fine. Go track it, Ray. So also the ostial profunda has a lot of diseases, you guys saw. So we're just going to pull this out and pull the catheter back and direct it into the SFA. So we're just going to track this vert tip catheter down. We have the access, Karthik. And I think Karthik and Raman, anything you guys would do different here? We're just going to track it down to the popliteal.
No, I think that's what I would do. I mean, that's exactly the plan, right? I mean, you put the wire in there just in case.
And yeah, I don't think we're going to do any harm to this vessel by having a wire in. I mean, obviously, if we put a sheath in or something like that, it may become worse. So here, what I generally like to do is take just a high mag picture to understand the stump. I mean, we do have a stump, but I really want to understand that collateral as well. Yeah. Anticoagulation-wise, what are we doing here, guys?
So we give her bivalorudin, Angiomax. Yeah.
So we give her bivalorudin here.
Well, the idea is you don't know how long the case is going to go on for, and you have 2 vessel access. I don't want the AT to shut down, so that's why we decided on giving a bivalorudin.
Make that a roadmap, guys.
Yeah.
So what we're going to do is we're just going to try, so you can see the significant.
Looks like a favorable stump.
Okay.
Yeah.
Very favorable stump, and you've got a very significant lesion at the level of the pop. So I'm going to go back with a woolly wire again, and I'm just going to advance a very soft tip wire to get it into the stump.
Piki, you have a aqua tempo right there, right?
Yeah, we always use aqua tempo, as you know, and it's
you're going to put aqua tempo through that lesion.
I don't know, Karthik. I think I may. I mean, the question is, we'll probably use this to try to cross. I don't know. I mean, I'm open to whether you guys think we should cross from below or above, because, from above, that collateral is right there. Crossing from below might be more elegant here, and then allowing us to, not mess with that collateral, until we've crossed. But the idea would be let's see if this acts like a thrombus. Nope, it's not acting like a thrombus.
Obviously, it's calcified, so
right.
It's definitely...
Correct. I'm going to just kind of stop there, And the question is, leave this in there for now. The question is whether you think we should come from below with a command wire and see whether it goes
I
through
think you
with a
should
support
probably
catheter.
come from below and see. That's probably the best way to do it.
Yeah, I mean, the idea is to, these collaterals are so important. I do not want, all you guys to take it lightly in terms of these collaterals. I mean, these are very, very important. So what we're going to do is we're just going to try to play with this wire, see where it goes. If the wire goes smoothly, it goes smoothly. If it doesn't, it doesn't. So it's definitely not going smoothly, as you can see.
It's
quite calcified.
It's very calcified.
So the question is whether you want to put a support catheter or we could try from above. What do you guys think?
I would probably put a support catheter, 014 support catheter, and just see. I think probably that will be the best way to do it. I mean, you can always try from above, but
I think I would actually. I'm gonna disagree. I think
that's fine.
I would see if we can get a little bit more purchase from the
above.
antegrade and see if we can kind of decrease this distance. Because from that angiogram you had the DSA of where that AT was. It's hard to see how far that is from the true distal pop.
Yeah.
Because I'm not sure whether that was a true ostium of the AT or whether that was just a little bit distal to it.
Yeah, you're right. You can see how the AT ostium is pretty much like the bend is 90 degrees. It'll be harder. And the stump, like you rightly said, is more favorable from the top. We'll see. Hopefully it connects.
Yep.
But I would probably in this case agree with Raman trying to go with an 014 stiffer wire. So that we don't want to create big planes from top, and then it's harder to enter from either ends.
Yeah.
And if it fails, then you're right.
Yeah. Then we go from below.
We already have access.
So let's pull this wire out, and then give me a shaper ray.
So I'm gonna just play devil's advocate over here for a second.
Please.
This is a complex case, and we've had cases like this all the time. We always talk about what is the best endovascular first option, and that usually ends up being the basis of what all of our our discussions are. At what point would you look at a patient who's, as Luca has presented very nicely, she's had multiple interventions, multiple rounds of ISR, and has needed multiple endovascular interventions. And this patient who's having quickly progressing symptoms from claudication to rest pain to now concerning for just nearly like almost ALI type symptoms, would you consider that an option of just sending her directly for a bypass, considering how complex disease at the level of the DFA, SFA is?
The only problem here will be it's going to be a femtip bypass, right?
Yeah.
So the femtip bypass patency is not going to be as great as, I think, giving her an endovascular option. And I think femtip, yeah, I mean, you can go either ways, but if you really look at the femtip patency, it's not going to be as good as your endovascular option. If you can get a good crossing, I think it's a nice AT. I think you'll have a good patency rates.
Well, obviously we're going somewhere.
But that's something to think about, definitely.
Yeah, I mean it's a good option. I mean, but if you have a vein graft,
that,
I mean we discussed with her a lot.
The direction is fine. Yeah.
No, you're right, Karthik. I mean, if you have a vein graft, then femtip might still be a good option in her. We already sent her for an endarterectomy. She's at high risk, low EF, multiple interventions, cardiac MI. So there are other comorbid conditions. Of course, like you said, surgery is always an option here if it fails. But I mean, I got her off the smoking and everything, but it's one of those options you want to try in this case. And if it doesn't work, then a venous femtip bypass.
Good.
See, this is why we got below knee access to kind of guide us to both ways here. So I think what we need to do is get a support catheter from above.
Yeah. Correct.
Then we need to get a support catheter from above. But let's start below. Give us a Cook. Actually, give us a fine cross.
It looks like it's floating, like it's went into a big plane. Looks like so.
Well, it might just be layered thrombus, is what I'm thinking.
Okay.
It might be layered thrombus in this level. So let's go with a fine cross from below. And then, actually, we can go with an O&A Trailblazer, right?
Yeah,
so we have options of wires. We got a Trailblazer. Don't open the fine cross.
Yeah.
So you're with the Confianza from the top?
Yeah, we just put a Confianza. I've got an 035 catheter. I just thought it would go easy. It's not. So I think, like you said, Karthik, I think we go from below, and then we have the option. And then I know it's single vessel. We've got a micro tip catheter with a micro wire here. And then we'll let Vishal play from below. Luke will just rail my wires. They go in. Let it come back. It's fine. So
the idea is sometimes these short CTOs, they might look. Oh, what's your wire?
Show me down.
Yeah. They might look very short and tempting, but they could give you all the trouble in the world because.
Rail guys.
Yeah. He's railing.
Okay, good.
But then, one second.
Wire came all the way back.
Yeah.
There you go. That's right. Loop is great. Great. Hold the loop. So which is good to get a nice loop because now you can, be confident in pushing and getting this thing up. So we need to give some cocktail now.
So, I mean, clearly we'll cross this, knowing our track record. But what would you do after you cross?
Well, I think I mean, it's the level of calcium that's really concerning to me. So I'm having a little trouble pushing this, but it's going smooth.
I mean,
Right there.
think
Still with a little bit. Right there.
Lose the wire now?
Crossing, I think we'll see how easy it is for a crossing catheter to get across, and probably to begin with a very small vessel.
Good, excellent.
Nice.
Okay, hold on.
I like that.
Hold on.
But now, like Karthik was talking about, we're talking about two different
planes.
planes.
Let's stop there. Now let me just
entire plane. And then to get to the final result, we have to see what exactly will be the size mismatch between this popliteal and this AT. It probably will end up needing stenting all the way over there, and then from the distal pop into AT, we'll probably be able to use.
Keep coming, bud. You might want to change wires now.
Is Shockwave a possibility here?
You want to try this?
The whole calcification in there. It looks more
Excellent.
like an adventitious cal. I like that.
I like that a lot.
Yeah, no,
let me try to rail me.
But I probably thread your catheter down there.
Okay, that's as far as this thing is going to go.
Yeah, no, the trail.
Yeah, see, now you need to get a
stiffer
wire.
Which wire do we have on the
rail the wire for
AT?
This is just a command right now.
It's just a command.
Wow.
Yeah.
Okay, good. Hold this.
I still like that path, Vishal.
Yeah. It's now I don't have much support because that's where I think the.
Yeah, I think you're gonna have to switch. This is the problem with these little micro catheters. I think you might have to go with a
stiffer wire.
Stiffer wire. Give him a confianza here.
Yeah.
But either way, I think we should change the catheter out.
Yeah.
Yeah, use the one from above is fine. Give me the command from above. Give me the command now. I'll try from above with the same command. So so I think that's a good question. I think the question is how would you guys manage this? This difficult step down that you're dealing with. I think I agree with Ramans. I think we need to go ahead and get it cross first, and then maybe either IVUS it or do a give me a Ashtato 21 guys.
Okay.
IVUS it or do an angiogram to kind of assess it. But I think IVUS is going to help a lot. And the question about the bypass is an excellent question. I think, Raman, if it was a short bypass, like a femoral to a tibial, I kind of agree with you there. I think that makes a big difference. But here you have a long segment where Karthik is saying you're actually going to come all the way from below, from the common femoral all the way down. And I think this is an occluded vessel. As long as we leave the tibials alone, and we don't disturb the tibial, this is an area where they're likely not going to touch down the bypass anyway. The key here is going to be careful. You're stuck in a calcium. Yep, yeah. Counterclocking? Counterclock and take it out?
Yeah.
Yeah, see, and we end up leaving endo trash and stuff like that. So actually, let's lose that wire, guys. Let's do another wire. That wire's already unraveling.
Yeah. You can see the tip being unraveled.
Yeah, the tip's already unraveling. So I think, having said that, I think I'm very comfortable here, and I think our surgeons would agree with me that this is pretty reasonable attempt here, as long as we don't ruin the distal target. The idea would be, I think eventually, I think you're 100% right, Raman. I think this patient will end up needing some sort of surgical intervention.
Correct.
But I think at this stage, I think we can avoid the surgical intervention by doing something different, which is, obviously something here.
For the audience, I guess.
Let's do a quick angio here.
Yeah.
Hold on. Pull this back, right? Yeah. DSA.
DSA it is. Well, for the audience, the importance here is we are. In this case, like you see, we got a primary pedal access as well. So it all depends on the etiology. We are aggressive enough in getting pedal accesses if need be. Some cases don't require it. But in this case, we went heads up pedal access because that's where it was the need of the hour. So all this.
My worry is I don't see that AT filling right now. Maybe we're just
creating it. If you see the ostium of that huge collateral like you were talking, PK, in the previous picture, if you played.
Yeah, play C minus, guys.
Yeah.
And did you guys give any nipride through this?
I don't know if it's a spasm. It looks more like a spasm to me. See that ostium?
Yeah, I'm a little concerned because it looks like the AT is completely down.
Yeah.
So the idea would be whether these guys did we pull back a little, guys, from this and make sure.
I'm going to give blood flow.
Back?
Yeah. There is blood flow.
Okay, good.
I'm just going to give some
nipride and garapamil.
Yeah.
So as they give nipride, let me just keep working from above.
Where's your catheter? Oh, you pulled
It's
back?
way up. Yeah, I had no, we pulled that catheter back for now just to kind of see where we are.
Yeah.
Yeah, this is not going to be a good situation.
Wow.
It is a rock.
Yeah, that's what I'm saying.
Yeah,
You might have to create a plane there, PK.
Well, I might just go down with an 018 catheter here and then turn out for a start at 30.
Yeah.
Start from below, Vishal.
Well, I need they're getting me a
because you're very
from
close to the distal tip.
starter?
So that small segment, you might have to create a plane because it looks like there's a huge, significant calcification there. Mainly adventitial looks more like adventitial and intimal probably, but medial.
I think that what we need to do is, like you said, we might need to change out for a support catheter from above. What wire is this?
That's an starter from down.
Okay, well, you're all the way down below, so be careful coming out. Okay, be careful.
I would be careful with our starter there.
Yeah, rail it.
Hold on, one second.
Rail.
Yeah.
Pull back. Pull back. Now give some dive from the bottom, Vishal, for me.
Oh, from the bottom?
Take that out and give dive from the bottom.
Pull the wire. Look.
Get me a trailblazer from above, guys. 018, yeah. Nope.
That calcium area is like deflecting your catheter completely, like the wire completely, like.
Yep, I can see it. Ready?
No, I need to pull back my catheter. I think it's just hubbing, so I have no blood flow right there. Okay, now.
Okay, DSA.
DSA is on. Injecting.
So we're in the wrong vessel.
Yeah.
We need to get into this vessel. So you see we've been going into the wrong vessel the whole time. So let's roadmap that, guys.
Hold on 1 second.
Interesting.
I think we were in the. I think now we went into a wrong vessel, but I think initially we were fine.
No, I think we were in the wrong vessel the whole time.
Okay.
Ready?
Yeah.
And that's probably that big collateral that was coming off of that proximal popliteal. Interesting. I mean, this goes. I mean, this for everyone watching. I mean, this goes to show that this is even the greatest of operators always have to take a step back and kind of just recheck and reassess. Because these cases are very, very challenging, obviously.
Well, yeah, I think that's kind of the idea, to do both. You need to do a little bit of both, and then you need to check it and see where you are. Obviously, if you created a nasty perforation there, it would have been a pain in the ass, but luckily we didn't. And now it may now hold on. Now I'm going to track this in. Rail, please, Michelle.
Hold on 1 second. Yeah.
So I'm just going to take this all the way to this spot, which we believe is going to be your AT. Yeah. I mean your popliteal. So now I'm going to come from above and below and see whether we can meet our wires. That's not it for sure.
Can I get a
right?
torque?
Yeah.
Yeah.
Okay. Well, that's probably another collateral from above. Okay. Give me a 018 trailblazer from above, please.
Vishal, you think you can turn the wire a little bit more
Yeah, and
medial?
I'm trying to do that.
Like medial?
But yeah, I am trying to do that. Hold on, I'm just getting a torque. Give me 1 second.
018 trailblazer, guys, from above. Yeah, now give me a Terumo gold tip. That's going somewhere else.
Yeah, there's a lot of
calcium.
Big rock.
Yeah.
See how it's deflecting me off that calcium?
Yeah.
That's the problem. So.
Well, just make sure the wire doesn't unravel.
Yeah. No. It is.
That's the key. Sorry. Yeah, I think you should switch for.
You're making some progress. Something's happening there.
It's just
It's a weird direction, but
yeah, no, it's right.
Okay.
It's
I don't like that.
It's too eccentric. Which
It's too eccentric from that calcium. Yeah.
Yeah, with calcium, which is what I don't like because it's going to give us an issue.
That looks better.
That looks better.
Direction.
Yeah. Then your perforates are going to go up if it's that eccentric.
Can you give me a little bit catheter support from the foot?
1 second. Let me just get this catheter down there. Wait
Sure.
guys. Okay. Ray, you can pull the wire back, Ray, if you need to. All right,
you take it's okay. Hold PK as well. That's fine. Let go. I'm not doing anything here. Just hold the PK for rail. That's it. Got it?
So we're just going to get this down there. We're going to give a little test from this catheter and then restart from above and below. So pops are always very difficult because of the calcification.
Yep.
So what we're going to do is see the wire went somewhere else here, but which is fine. I hope we didn't perf anything. All right, give me above from below. Turn off the max for a little bit, ladies. Thank you.
This is an 018 Trailblazer from the top?
Yes, it is, Karthik.
Yeah, perfect. Yeah. That's probably best.
Let's actually talk about that for a second. When you're doing these cases, PK, VK, Luke, how do you progress through your microcatheters? What's your basic escalation strategy when it comes to choosing these?
There's a collateral there. See that?
Yeah, I think
the
that's
collateral we were in. All right, so give us a
so it's like the smallest. I mean, start with the low profile microcatheter again, like we're talking about creating these dissection planes.
I like that.
Trying to re-enter.
Yeah,
so you're right. We start with an 014 and 018. Usually an 018 because it gives you flexibility of using the stiffer 014 stiffer wires and the 018 stiffer wires. So 018 microcatheter, good support. Chances of getting the dissection is on a lesser side. So.
Vishal, do you want to progress? You're progressing anything from below, or?
No, I'm starting now.
I'm just pushing the catheter off of Vishal. It's gonna break through at some point. Maybe
my tip has straightened up because of that.
You want to go with a 2-1 wire?
Yeah.
020 wire. Got a feel the wire, guys?
Yep. It's not a bad idea for you to take a Terumo Gold from below, actually.
I agree.
Yeah.
Yeah, you might fall into that plane.
So now I'm dissecting.
Yeah. No, that's what I'm saying. The Terumo Gold might fall into that plane. So.
Yeah.
Yep, you're gonna have to dissect here. Give me that. Thank you, Luke.
Question is if I can.
You have to, but it should just be more central dissection than an eccentric dissection.
Yep.
I'm going to try to break through that cap if I can. But again, the problem is the unraveling part of it. Okay.
Yeah, you don't want to unravel this wire. And let's see. We're almost there.
Let's get a Terumo Gold.
It shows all the challenges we face.
Popliteal calcification is probably the worst to have for us, right?
Yeah.
Wow.
Yeah, you're right. All the way from anatomy to crossing to stenting, everything is like a lot of different strategies.
PK, what wire are you using right now?
I'm just using a fielder, trying to see if there's a plane or something. Doesn't look like there is. All right, give me I start at 21 again, Ray. 20, I mean.
Look, can you put a torque around it?
A little bit of dye staining now down at the level. May have crossed into a vein or something as well.
See, it's now.
No.
That's the plane. That's the wire plane.
You're right next to the vessel.
Popped out. Yeah.
You're next to the vessel. Don't push it.
No, no, I'm just the wire feel.
And we've turned the anticoagulation off for now?
Yeah.
For now. I mean, we're on Angiogram, so we should be good. Give me a little dye from above, guys.
Yeah.
Staining.
Yeah.
Watch the stain, guys.
Looks more like a venous stain.
Yeah.
Yeah, it's not a big deal.
Yeah.
Yeah. I'm sorry.
The safest of all contrast extrav.
Let's see. Nope.
Oof.
See, I'm dedicated to the.
Vishal, what happens if you take a command and form a loop from below?
Yeah, that's what I was trying to do. I mean, I'm okay with looping and trying to find a.
Yeah, because you have to change that
exchange it for a little bit stiffer, a staro like a 30, which is an 018, 30 or a 40 to try to see if I can break that calcium.
I like PK's way.
It's very, very close.
Can I have a staro 30 or a 40?
You're also getting deflected by that calcium, so.
Correct. I think that's the whole thing.
Leave the wire there, guys.
Yeah.
Okay. Okay, Rochelle, pull your catheter back slightly.
Yep.
Just stay there for me. Give me,
Yep. Taking a staro.
I think your path is okay, PK.
Yeah,
I think you're getting distracted by that staining, but I think your path is good.
Yeah, I agree. It's just got to keep. The question is, where is it going to go? Is it going to make the turn or not? Let's see.
I think it is. It's a very favorable angle of AT, so. Hopefully it's going to
come back just a touch
30,
and
40.
try to redirect.
Like an over an eighth.
No.
Let me try from below. I'm just going to use a stiffer wire.
Mm-hmm.
And try to poke through that. All right, I'll give it a little bit.
Okay. Give me a Terumo Gold from above, guys.
Here
All right, Luke. Let me see. Let's see. What other thoughts can we have here? We could try external beam ultrasound to see where we are.
PK, what happens if you from there, like where you are, and from Vishal
There you
where
go.
he
That's a lot
is,
Right there.
yeah,
I kind of like
where
that.
he is.
Yep.
That's a
Okay. Hold
1D.
on. Oh, okay.
Okay.
Hold on. Stay.
Oh,
Stay.
wait.
I am. I'm
No,
not going.
He's good. He's good. He's good.
He's like,
So,
Vishal is like running away.
No, you got to pull back, Michelle.
Yeah, no.
Okay, stay there for me,
Okay.
and let me come from above and try to see. Give me a little dive from above, guys. Ready?
Mm-hmm.
Vicky, can you talk a little bit about the tactile sensations you had when going through this plane as opposed to the previous ones?
Yeah, it's just it was just look more like you said, it looked more intraluminal. The field, the wire was spinning much better. It wasn't looping, or you know how you deflect it if you've perfed through the vessel, if you're in the subcutaneous tissue, how it perfs and buckles. It didn't. So that's another sign that hopefully are intraluminal. And all I was looking for is just a little bit more extra support. So that's why I use
it's also the what we're trying to do here, why we're going with two different wires is you want to try to dissect the proximal cap as well to try to break through.
Right.
So let's see whether now, Vishal, you keep coming from below. I'll keep pushing from above and see. We'll see, that's the cap right there, guys. Nope, you're going. Okay, keep coming, Vishal. I'm okay with that. Let's see where you go. Keep coming. Keep coming. Keep going. Stop. Yes. Hold on. I think you crossed. Hit the above from above.
Ready?
Let me just pull my catheter back a little bit. Nope, not quite. Not quite. You're almost there. Okay.
I think you're almost there.
Hold on. No. Where'd you hit that button?
No, I didn't.
Okay, so let me show me above here. Let me bring my catheter into the plane here. There's my wire in the plane. Okay, there we're crossing. Hold on now. Let's do a quick roadmap here. Inject.
Yeah.
So now we look like geniuses because we got the dual access, right? So we're crossing right there. So hold on, let me come down with this catheter here and just leave it there for Vishal to try to steer into. I'm going to pull my wire back, and I think the best way to do is just try to steer from below into this catheter. You got to pull back a little and redirect, make it point medially, and don't twist it, poke it. So yep, medial. No, medial.
I am.
There you go. That was medial. That's still lateral. Got to hold it when it's medial and just push. Right? There you go. That's better. Excellent. You're definitely in the vessel, Vishal. I guarantee it, because the way it's moving, I think you're in the vessel. I just think you're dissecting in a dissection plane. Okay, let's try to give him some support from below. Flora. There you go.
Right there. Oh.
Just hold. There you go. Now, hold on. Let me pull this catheter back for you. Okay. Yep. Now, show me. Yep. Now you're in the vessel. Move the wire. Good. You're in the vessel.
Yeah,
now, that's excellent.
In the vessel.
Good. Save that. Now let's go ahead and pull this back for you. Hold on a second. Okay. Try to see whether you can wire it. There you go. Nope. Right next to it. Don't dissect it, obviously.
No.
Get us a better catheter array than this. A bigger catheter for him to wire.
Vishal, it's like playing joystick. So there you go.
No, I missed. I hold it up against the wall here because I need to just give you a better catheter, Vishal. And then we'll just externalize it. Here, hold this. Let me just push this back. Pull this back. You keep trying. There you go.
No, I just don't like the way it points.
I don't either.
Yeah. Just want to be really sure.
Well, you are really sure.
I know, I just
to make sure. No, it's in the vessel for sure.
I lost my bend on the.
Yeah, the amount of movement that wire is making, it's definitely in the vessel.
Let me push you from above. Hold on, below.
Unless,
okay, rail me, Vishal.
Hold on. Yeah.
Either way, we're very close. I don't really care now. Okay, sweetheart, hang on. So this is important, guys. I'm holding pressure on the AT as I'm advancing this wire, and I'm giving her a lot of pressure on her vessel as I advance this. That's good. Okay, I'm sorry, honey. I'm sorry. Okay, now let me come from above. Did you guys get me the vert tip catheter here? Oh, you're out again?
Okay, yeah.
Just the above, these come in sort of in a higher level, isn't it?
Yeah, that's what I'm saying. I'm just. Okay.
I don't know. Maybe he's not in.
Yeah, that's what I'm thinking. The way it buckles right there.
You want to take a picture and see? But the way it moved, it definitely looked like it was.
Well, I think he lost the position.
I think you lost the position, Vishal. You might have to redirect. You have to pull back and redirect it again.
That's what I'm thinking.
Well, now you created a nice dissection plane there. Give me the diode loop for me.
Yeah.
No, I'd like you to come down and redirect, Vishal.
Yeah.
Pull back.
Come to like the mid pop level.
Or you see the calcification?
See.
This is not a good view. This is a better view. Hold on. Okay. So pull back below.
Yeah.
Pull back. Pull your catheter back. Let me pull your wire all the way back now and restart.
Yeah.
There you go. Now pull your yep.
Well, there's definitely some wire interaction, which is good.
Vishal, I don't know. I think you're still dissecting it.
Yeah, I think so. The way it buckles.
No, I think you're still dissecting it.
Hold on a second.
The wires are nearly intertwined here.
Okay, now stay there. Now I'm going to pull back here. There you go.
PK, I don't think Vishal is in the vessel at all.
I'm still dissecting.
He's still dissecting
it.
Get a
feel?
Yeah.
Let me just get a feel from below.
Problem is, a stiffer wire sometimes can give you.
I'm just going to pull this catheter back. Don't worry. I'll just pull it back myself. Okay. Yeah, I agree.
Yeah, now
it's in a plane for sure.
Yeah, that's another.
You're not in the, Yeah, I agree. Little die here, guys.
I think you can create a loop from above and then re-enter it. That's not a bad idea to do it.
What another view for me, Ray?
I think it looks more like an overlap for me.
I agree. I'm on top of it.
Yeah, you're right on top of it.
It's just on top of it.
Well, I'm going to keep coming down. Okay, let's back a little more here. There you go. Now it feels like I'm in the vessel. Okay.
Yeah, that looks like a good direction. That looks like, oh, that's nice.
Well, I think now I think I'm side of it, brother.
Yeah, it's just, you see how, there.
Is she moving, Ray? Is she in any pain?
If I go all the way right there. Yeah.
Nope. No, I'm on top.
PK, what happens if you create a loop from above, dissect it down, and enter into that dissection plane?
That's what I'm going to try to do, Karthik. Now let's leave this here for now.
Yeah.
Give me a
instead of because I don't want to go create a plane behind that collateral, like you said.
And this may be actually a good time to consider using like a facilitator reentry with a balloon, because this we have such a small area.
If you create a big loop on there, like near 30.
Yeah, I think loop is a good idea. We just loop
30.
It and just try to...
Then you'll create a big plane, and then it's easy to fall into that plane from below instead of falling.
So actually, from below. Okay, give me that oven, the Turumo gold from below.
Okay, give me the Turumo gold from above too, guys. Give me a Turumo gold. Okay.
Interesting.
Oops, sorry. Thanks.
Calcification, the Achilles heel. So, all right. So.
All right. So now let me see here. Let me just take this down and further. Get to there. All right. Let's do a roadmap, Vish.
Yeah.
Let's do it here. Ray. Let's do a quick roadmap.
That's good. That's good, PK.
Okay, that's good.
That's good, Vishal. I like that.
I'll stay there.
Yeah.
Good. Now let me give you catheter support. Now staying within the. Now let me give you a little bit of. Hold on. hold on.
Make that loop.
Okay, now let me give you a little dye here.
Yeah. Just want to keep that loop thin.
Let's get off the glow tape here.
Maybe.
There we go. Okay, hold on now.
Mm-hmm.
Right, check Angiomax for me.
So right there, we just have to
loop is a little large, huh?
Yeah, still a bit bigger loop for.
Vishal, I would not push anything further.
No, I'm not. That's why
I would,
right at the
I would fall in from above if I have to.
Stay here for now.
Yeah.
Give me the Terumo Gold Ray.
Because that's still the plane, remember? So
correct.
Yeah, if you
take this
big of a loop,
is just get a catheter a little bit closer, get the loop off, and then try to find a. Because we're right on top of it. I mean, of course, not in it. So we could do that strategy. Just lose the loop and then try to re-enter.
You're so close there, you can even, I mean, the only thing is the collateral comes so close to the distal hub that I don't want to re-enter at that point. I would prefer to re-enter it like at 30, which is below the level of the...
Maybe guys. It's easier to loop from the top and I lose my...
Yeah, agreed.
Yeah. So at least the dissection plane is down rather than going up and then extending it into the collateral.
Because at this point, we're going to stent it anyway, so...
Correct.
Look at the difference we are.
Complex.
The wires touched. I see the wires moving. I saw the movement of the wires, both wires. Vishal, you want to reduce the loop a little bit?
Yeah.
Let's see.
Hold on, Vishal, for me.
Sure, I'll hold on.
No, that's not what I want here. There you
right
go.
There.
Problem is where Vishal
you're in two different planes.
Yeah.
Mm-hmm. Okay. Let's give a little.
PK, what happens if you get the loop there and like Raman suggested, facilitated re-entry, like with the NTR or something?
Yeah, let me see. Let me get a feel from below Vishal.
Yeah.
Hold on. I just want to see whether we can enter. I mean, I like the loop where it is, but sometimes the gold tip really works really favorably for us. Yeah. Let's see if I can lose this loop.
Correct, exactly. Lose the loop and then you can probably flip over.
I just think that we're still in this plane from below.
Yeah, we are still in that same plane, like what we were before.
Yeah, now it's everywhere.
So the plane is so big, PK. I think it will be very easy to do a balloon re-entry from above.
Yeah, I agree.
Just get the balloon and just the plane is like really big, so it's very easy to just pull it in.
See, right.
This is my helicopter here. Let's see.
You're right on top of it. I mean, that's one from this angle.
Are we through? I wonder. Am I touching the?
We're all the way into the distal pop.
I don't know if it's going though. No, it's not going. Nope, I'm dissecting.
No, look. Yeah, I mean the whole.
No. It's just the dissection.
Yeah, it moves the whole vessel. Yeah.
Yep, you're right. Yep. So the question is now whether we put a catheter. See, we've created quite a big loop here, which is good. So now we can come from above and see whether we can break in.
Just balloon it and then just.
Okay, now give me a shot from below.
Or the other way around, start from top, trying to break it through.
No, I think we've created enough of a tear here to be able to break in. So give me a Confianza from below, Ray.
Yeah.
Confianza. So, okay, it's 8:45. So let's see whether we can get this through. I'm sorry, guys. This is more difficult than we thought it would be.
Yeah, no.
I think it's great. I mean, it's a great teaching point. So I think it's just the amount of calcification is so significant.
Keep coming. Keep pushing.
DK, once you have a moment, I think it would be interesting for you to talk about this technique that you were just alluding to.
Yeah, so the helicopter technique is, so I think when you do these dissections, what you're doing is just spinning the wire within the dissection plane and then trying to just go ahead and tear back into the true lumen. So yeah, this has been described quite a bit. We've done it quite a bit. It's been described in Europe. It really works really well in these kind of complex calcified dissections. So I think I just use it. My concept has always been what you want to do in these kind of lesions, because unlike the coronaries, here the collaterals are very important. Generally speaking, these small collaterals that you see are not very important. So I think that you're able to do it here. There we go. Come on, right in. Come right to Papa. Let's see. Let's see. It's not going to do it here. You wanted to do it so bad, right?
Yeah.
But you probably need a steerable wire, Vishal.
Correct.
Probably need something a little bit better than that, like a coronary confianza or something, which might help you. Let's see whether we can. There we go. Are we crossing? I wonder. A little torquer here, guys, for me.
Yeah, let's get a confianza and a starter from top, and we'll try to just connect.
I mean, if not, we'll balloon it, and then we'll do a facilitated reentry from above.
Yeah.
All right, do what you have to do, Liz.
And that way you also will be able to control the reentry too.
Yeah,
I
think so.
Right
in the mid pop.
Exactly.
Yes, if you need to give
inflate the balloon right at that cap.
Okay, now move your cap. Now move your wire,
reentry is at the level.
Pull your wire
you're
back.
actually going to be sparing that massive collateral that's been kind of saving you.
So you can stent it right to the level of that core.
Exactly. Yeah.
It's much easy to.
Pull your catheter back a little bit, buddy. Okay.
Are we touching?
No, we're not touching.
No, it's just like
torquer. Thank you.
So we are still on top of the vessel.
You have the confianza.
Wait,
moves.
What do you have for wire?
We have a 30 if you want.
Yeah.
I think you might need an Estado 30.
Yeah, I'm doing that right now. No, I'm going to take this out. It keeps going in the same plane.
So Vishal, do me a favor. Bring your catheter down further toward me.
Okay.
Yep. Keep coming down. Keep coming into the plane.
Yeah, maybe this is a good time to sort of maybe briefly talk about all the other re-entry techniques that we can use. We have a lot of them are extrapolated from the coronary world. But this idea of the facilitated balloon re-entry is one that I think is more unique to the endovascular world. The concept being that you'll have a balloon that is inflated in a dissection plane, and from the retrograde approach is wired directly into to puncture the actual balloon itself, and then pull that system all the way back from the antegrade to then create your two connections. Obviously, we have all of our reverse cart techniques as well, which are also quite effective. I'm not sure how effective they'll be in this particular, considering the short segment and the actual size of the dissection plane we've actually created.
Yeah.
So I think the facilitated balloon reentry may be the best.
Yeah.
Also, I think we have created such a big dissection plane. I mean, if you take any reentry balloons, like we have like crosspass or stingray or entier, it'll just fall in.
Go to a different view now.
At this point of time, I think this space is not a good space for mechanical reentries like
Outback or
Pioneers.
Too big.
Too big. Especially with this amount of calcification in POP, the risk of perforations are very high. I think we're just in two different planes.
Yep, agreed, 100%.
Yeah. There are some operators who do reentries, like mechanical reentries, even in POP, right, PK? If I'm not wrong.
There are. I mean, we've done them too. Your wire is not in the
no. Just my torqueability of the wire is also an issue.
Okay, move your catheter for me now.
If you really have to do a mechanical reentry, I would probably choose a Pioneer, where you have a little more imaging to guide you. What do you say, Vishal and PK?
Move your wire, please, not your catheter. Wire. Pull your wire back, please.
Oh, wire back.
Still in two different planes, looks like. It's because it's overlap.
Yep, I agree. Come. Now come down in that plane, Vishal. See whether you cross here. Okay, good. Let's go to the other view now. Okay, we're way off.
Yeah, we are.
I think Vishal is more. I don't know. Both of us are off.
Yeah.
The question is, which is the right plane? So the idea would be. Nope. Okay, give me a Terumo Gold from below here, guys.
Okay, any reason why we are not like you want to still see if you can fall in or
this might.
No, I mean, we're just trying to create. There you go. Let's know you're again.
No,
gonna
I'm
be a
again
different
in
plane.
yeah.
I mean, the idea here, Vishal, I mean, the card thing is give it a few more attempts, and then we're going to go with the balloon from above, and then try
Vishal, I like that where your wire is.
Yeah.
I like that. I like that very well. I think you fell in.
There you
I
go.
think you fell in.
Much better.
Yeah. You fell into the
Come down.
same
There you
plane
go.
as
There
you are
you
from
go.
the. You definitely fell in.
Beautiful.
Yeah,
Are you in the
Nice job.
catheter?
Save
Yeah.
that. Yeah, you're in the catheter.
Wow.
Well,
Look
listen.
at that.
You
There you
definitely
go.
looks like you fell in. Yeah.
I don't know.
So again, guys, the whole idea is you create the multiple planes, and the multiple planes will tear the vessel, and then you'll be able to go ahead and do this. So now we're just going to walk this out. Save that for a second.
Yeah.
So again, if you don't do the dissections, and this is what I keep wanting to tell you. See, the idea of doing these multiple dissections in these planes is try to create a dissection of the calcium spicules in order for you to be able to get in. So that's the concept. Walk this one out now, Vishal.
Yeah.
You can let some blood flow. Well, no, wait. Yeah, you can just walk it out.
Yeah,
just push the wire.
And
just
the
walk it
wire,
out.
right? Yeah.
Walk it out.
You have to
now.
externalize the wire.
catheter.
You have to.
You know what?
Vicky, you want to externalize that wire, right?
External.
You want to externalize it? Okay.
No.
Yeah,
Okay,
I mean-
we already
I
externalized.
agree with Karthik because I think it's going
No,
to give
because
us.
this is a stiff wire, right? This
Yeah,
is an
yeah,
astrato,
yeah.
right?
Yeah,
So
yeah,
why
yeah.
don't you externalize this
Correct.
and
I
then
got a
put the
good
balloon
idea.
over it and then take it out,
Hold
right?
on. Why don't we just push
Push the
push
catheter
the
from the
catheter
top.
as
From
far
the
as it
top.
goes and
Yeah.
cross? That's
That's
all.
it.
One or the other. Let's see. So either the wire is going to come out or the catheter is going to come forward. There you go. The catheter is already there.
I'm gonna take
No,
my.
nope, it's not. So let me push this wire. And
Yeah, I think
externalize
that's
it.
where you're going to have the major issue. So you might have to balloon it.
Positive array on that.
Yeah.
Nope, it's not coming.
I think we need a CXI Navicross.
Yeah, I might need an Navic
Yeah,
cross.
this is
We're
not-
almost out. Let me see if it goes. Very positive on this catheter, please.
Yeah, maybe just I think just after all this hard work, we can definitely safely externalize
Yeah.
it and then
Externalize it from below
there
and then
across.
just
Then hold
cross
it
it
and-
and then
yeah.
change it. Yeah, just cross it and
Yeah.
change it to another
I
catheter.
agree. I
That's
agree
it.
with you
Or
guys.
take
right?
all
a
this work,
or take
you
a
know.
coronary balloon and just balloon it and create your
No,
trap.
I'll do that.
No, we're not out yet.
Easy.
After all this
won't
work,
believe
it makes the most
Yeah, and I'm
sense.
sure I can feel it. It's like the fear of kinking. It's on-
You should be out now.
Nope.
Nah, not yet. Oh,
Now you're out. You're out. You have to be out. Look
okay.
at that.
It's far
Oh,
away.
you're
yeah.
not
No.
out yet. No, you're not out yet.
Wow.
Lift that up
How
like
can
you
you
were
not
doing.
out?
Where
How
where-
can
Oh,
I
you're
be-
definitely out.
Yeah, it should be
Yeah,
out.
you're
I can see
definitely
it
out.
from far away.
Yeah.
Can you?
Yeah, you're
Ray,
definitely
can you
out. Just pull it out. Just pull out the catheter. That's it.
Hold on.
Wire
see?
is
My
out
axis was
anyways.
way above. Yeah.
It's moving away from the leg, PK. You're definitely out.
Wait,
Yeah.
Yeah.
Yep.
Yeah. Okay,
There's
let
a
me give you a
wire.
mosquito.
Yep, there's a wire.
Yeah. Just clip it and then.
It's like, holy wait,
Just
what-
clip this
what
for a
the heck's
second.
going on?
Yeah, I mean, it should be out, right? It can't be. I mean, the axis is somewhere at 30, so.
I know, that's what I. Yeah.
Okay.
Right, feed the wire to me. Okay, that's good. Good. Perfect. All right, give us a balloon now, guys. Give us a coronary balloon.
Yeah, balloon it, cross it, and then change it to a Spartacore. Now, that's great.
So now-
As
now we've
expected,
done the
took some
cross.
time,
This is
but I
just-
think.
Well,
But
Give
it's
us a-
it's a
give
it's
us
a
a
great
3-5
case
corner
to
balloon.
show how beautiful. I mean, how complex a simple CTO can look like and become.
but I mean, the point here, guys, is like, it's first of all planning, right? So you wanted to plan. Luke and I discussed it. We wanted dual access from the beginning because, listen, these popliteals with multiple collaterals are very difficult. Second is the choice of wire. Okay, so Vishal started with a command, made a little progress. Calcification was seen, and then we decided to go with two catheters, one from above, one from below, and then we started doing. Third is, because of the calcium, we were bounced off in all different directions. Now, what does that mean? Well, what that means is that we need to now, there's an 018 or an 014? What balloon is this?
It's
Because
coronary
this is-
balloon,
Oh, it's
right?
probably no, but the wire is it was an Ostaro 30, right, or 20?
It was a 30 from above.
Yeah, so it's not gonna go.
that
So give us an
balloon will go.
018 balloon,
Yeah,
guys. Give us
018
an
balloon.
018 balloon.
Yeah,
018 BART balloon, please. BD balloon.
BD. Yeah.
Yep. Give us a 40 or 30. 30 BD balloon right there up top. You have a 30? So again, as I was saying, while Damien tries to find it, we went ahead and did the multiple dissections, and that's the concept that I always try to teach, our fellows here is that, when you're in a dissection plane, you want to create these multiple dissections and not really worry about it. The idea is your loop cannot be too large. I mean, and that's important. So when we created the multiple dissections with the helicopter technique, this technique, that technique, what happens is you start rupturing these septae. Once you start rupturing the septae, then you work from above and below with a sharp tip wire, which will then allow you to go ahead and get the wire through. And I think that's what happened here so elegantly. So now what we're doing is we have through and through access. So we've got access here. So we basically have a coat hanger. And now what we're going to do is push from above and below. What length is this, Dame? 3040. So we're going with a 3.0 balloon into the posterior tibial, right? Anterior tibial. So let's see if this crosses.
PK and Vishal, what I like the most about this wire, it's so central in the vessel, in the middle of the calcium.
So far this has had the best much, which is really interesting because all the dissection planes were nowhere near this.
Pull that.
I think it's really interesting to demonstrate this point that PK is talking about. That opening up these fenestrations even more and just disrupt. Oh, beautiful.
So you see there, with all this, when Luke and Vishal railed us, you have a tremendous, pushability. Let's do a DSA. So I just want to make sure we're in the right spot when we balloon, and let's see. Now we're going to deal with probably a lot of spasm from above and below. So let's see whether that AT even lights up. It's lit up beautifully.
Yeah.
So it's a huge vessel. And are we in a good spot, Luke? I can't see.
Yeah, we're still above these.
We're still above. We can go down a little bit.
Let's balloon it. It's okay. We'll balloon this just to create our track.
We still have at least one.
Let's create our track.
So this is an overnight balloon, right, Vishal?
018 BD balloon by BD. And
I think once you create a track, you can get this balloon down to the mid 80 and change it to a SpartaCore.
6.
Pull this wire out and change it to a SpartaCore.
Yeah, I'm going to switch over. We just want to make sure there's good deliverability. Because I use an Ostaro 30, which is an 018 wire. 20 is an 014. So
now, what adjunctive therapy are you guys planning for this case now?
Well, right now we've
PK, Luke, before you balloon, PK, would you want to balloon across that collateral? I think that we have a nice nub, right? I think we can just end it right at that collateral.
That's but you see, there's a lesion right there, bro.
Right.
I think we just go ahead and open it.
But you mean
we'll be okay.
We'll be okay.
Yeah.
So I'm saying is we can, if you have to stent also, you stent it right to that level of that collateral, not across it. Because it looks like there is a small nub after it. So you can end your coronary stent there. So that way, just in case if something happens to that stent, you still have your collateral supply.
Okay. Perfect. Down. Okay, walk it back, Luke, a little bit.
The backup for the patient with stenosis or anything.
Okay, inject.
Inject. Okay.
You still have to balloon the proximal cap, and that's nice.
That's lovely.
Okay, lovely. So now we've got a good lesion across. I'm going to change that to an 014 SpartaCore now.
So put it back this. Yeah.
I'm just going to take this all the way down. Okay, now let's get a SpartaCore. Pull the wire out now. So
go in a little
pull
bit
it
more.
out. You want to go down a little more?
PK and Vishal and Luke, of course. Right? Yeah. You guys think there's any role of
Actually,
Shockwave in this?
Stop.
Yeah,
above is below.
Yeah,
above is better.
Yeah,
no, below is better because you have the sharp angle there. This is not sharp here. So pull out from below. Pull out from below. Yep. So I'm just going to take this
Give me
down.
a micro. No, hold on 1 second. It's going to
check later.
Yeah, just give me a dilator if you can.
Just feed this through for you.
Yeah.
Well, you can pull. Yep. Just pull slowly. Good. Any resistance?
Yeah.
A lot of resistance?
Yeah.
Really?
Yeah, I would probably pull it from above.
There's a lot of
the length is shorter there. You can put
but look at the tip. The tip is so screwed up.
Okay, hold on. That's what
I'm a little worried about.
Yeah. I mean, it's probably also like a good degree of spasm. You also have to take
I'm just worried about this tip here.
No, but this is a very smart technique that the VK is doing. Is taking like a microcatheter over the tip of the wire and inserting it into the distal vessel.
Yeah,
and then pulling. So
the tip is quite nasty here, guys.
The only thing you can do is...
You want to cut it?
Yeah, exactly.
Let's cut it, Luke. So we're going to cut it because we don't want this tip to tear the vessel. Vishal is having a hell of a time feeding it. Let's just cut it.
Yeah, let's cut it.
Let's just cut it. Let Luke and you just cut it.
The other
Come, Luke.
Yeah. Well,
best option. Cut it and just pull it out.
When we were pulling it, it really got screwed up. And
ready?
Yeah.
Gotta hold it tight.
Yeah, I am.
There you go.
Good.
Okay, good. So now I'm just gonna pull this out then.
Yeah.
Okay, it's out. Now give us a SpartaCore, guys. Give me some nipride through this catheter now. Nipride. I'm going to put some nipride through this catheter, and then we're going to give a lot of. And then now the question is going to be, what are we going to do?
Just a light.
We could go ahead and do. You want to go ahead and do any balloon angioplasty?
I was asking, is Shockwave have a role in this?
No, the balloon expanded quite well.
Yeah.
I'm not really worried about that.
No, I'm the distal part of that popliteal where the calcification is.
I mean, I think right here, Karthik, I think it's pretty reasonable. Okay, we can take a look. I mean, look at the balloon expansion. You'll see it's very good.
Yeah.
You know?
So now,
I'm giving the whole thing.
See that right where that the whole
AT
distal pop
takeoff
is? Yeah, where the AT takeoff is and the distal pop is, that's where your most of the chunk of calcification is, right?
Correct.
So, and also right where your proximal cap is, also at that point, I'm saying, especially above the level of the collateral also, there is a lot of calcification. I don't know if you, I don't think the plan is to stent across that collateral, right? Is it?
I mean, to me, I don't think an open cell stent would make a difference there.
Yeah.
I mean, if you need to, you need to. If you don't need to, I don't think it really matters. You
I've
know,
seen some
I'm
math
not
recommending
too
to that
concerned.
ostial AT is probably go.
Yeah, so why don't you get us an EXL? Let's do an EXL first,
I agree.
and then let's see after that.
Yeah.
We need a Spartacore.
Okay, give me a
Right
Spartacore now,
at that
guys.
ostial still needs to be treated.
So what we're going to do for the live case for everybody is we're going to do an EXL here, and then we're going to do a DCB and treat the pop. The ostial SFA will treat offline, obviously. It's nothing that's too complicated for anybody. And I think this is where the decisions had to be made by everybody. And I think that's the situation which really shows us where we are.
Nicely put a 4.0 stent from there. GS Megatron.
Yeah, you can put a Megatron.
Yeah, 4.0 and then expand it to 5.5 in the distal part, and then put a Supera there.
So yeah.
Or the other way around.
Yes, other way around.
I like the other way around better.
Yes, we figured it out, right?
Yeah, exactly.
Still bleeding though. There you go. Look.
Just P will clean you, Elizabeth. Got it.
So now we crossed. HT was off. Sorry, the Angiomax was off for a while. Have we resumed
So it's now it's restarted.
Restarted.
Its ACT dropped down to 260. Again, everybody knows that ACT is not a good marker in Angiomax, but we generally use it that there's something in the blood. So the ACT dropped to 260.
Oh, EXL.
So we waited. Once we crossed, we went ahead and did a what is it called, re-bolus with our protocol of 1/3 bolus, which again, we're following coronary techniques here, but we do a lot of coronaries here, and because of that, I think it's pretty reasonable to follow those, and it's been very effective for us. So now what I'm going to do is I'm going to just do a cut of the pop and also see whether we can expand this. To me, I mean, we could do an IVUS, but I think we're in a dissection plane. So is she bleeding, Ray? Just take a look. I don't think so.
She looks good.
No?
No.
Okay, good. So we're just going to go ahead and just do a quick EXL here.
And we're also going to have
Where's
to
the
treat that
pain?
PP,
lesion
no PP. Go.
Go.
before the
Before the
collateral
Yeah.
as well. So
That's what I was asking. Like,
that
what
kinda-
kind of stent
that
would you
kinda
want?
changes
Let's go cut.
the plans we were having about sparing that collateral. So we're going to have to
Off.
direct my DCB
1 second, let me just run it
and
through.
cover
here.
that
That's what I was
collateral. So I
thinking,
think that
Not completely off.
we're also
Nope.
so
Too
focused
much of a
on
bad.
everything distal that
Save
we
that.
kind of forgot about that.
Okay,
lesion.
I didn't like the bias there, guys, so I'm not going to cut. So I'm going to, that was a 3.0 balloon. So now give me a 4.0. Let's get an IVUS for me quickly. Let's do a quick IVUS.
Right here.
I'm going to do a quick IVUS to see where we are. So let's see
I
whether
don't
the
know
IVUS.
if one of those Serenator balloons would actually cross that
It's a very
ostial
bulky
GT
balloon,
lesion.
but it works.
I think the Serenator would cross, but I think that, I think right now the question is the expansibility. I mean, if Serenator I will use if I'm not going to stent.
Correct.
But regardless, Serenator, to me, I mean, there's a lot of, it's a good effective balloon, but it's not going to be my final therapy. So it's adding a lot of cost to me. So if I don't need it, I don't use it. I think that it's an effective balloon, no question. I think the form of angioplasty that it performs is very different. But regardless, I think that at this stage, the cost of the procedure, it doesn't warrant us using the Serenator because we don't need it. So I think at this stage, again, the same thing, we're willing to eat the cost like with the Shockwave in the past when we know we needed it to be successful. But here we've already crossed, and now we've done an atherectomy, at least of the proximal. Now we're going to go ahead and do a quick IVUS to get a vessel size and then decide. So this is the distal AT. Measure this as the AT, please, for me.
4.
So it's a 4.
Exactly 4.
Okay, so it's a 4 millimeter vessel, right?
Start recording,
so start
please.
recording, guys. So,
okay, recording.
So we're going to pull back slowly.
You to really see our entry point.
So you can see with the IVUS, you were pretty much central luminal. And even here, we're central luminal, right? So we're still in the vessel here, so that's okay.
Yeah.
A little bit of a flap there, like Roman said.
So there it is on the outside.
Okay,
So
now
it's
measure this vessel,
short,
please.
That's your
short segment of being outside.
bookmark.
So that calcification
This
is
is all
what,
calcium.
Yeah.
where is that, PK, on the marker?
That's in the ostium, in the ostium.
Yeah, that's what I was saying. Like
Correct.
the expansibility of the shockwave presence here. That's what.
Well, I think we could balloon with a 4 and then
4
decide.
and C. Yeah.
Yeah. So give us a 4-0 long balloon here, guys. See, we're truly in the vessel here.
Yeah. It's all internal.
Measure this, guys, for me. It's what? How
Have
many?
to bookmark it. The measure
Bookmark
after
it?
we stop recording.
5.5.
5.5. Okay. This will pull back. And now we're in the true lumen here.
Proximal
Yeah,
lesion.
it's still
Yeah.
5.5.
It's still 5.5.
Now it's like
So I think it might be reasonable to use a Shockwave.
Yeah, it's a concentric calcification.
Oh, right there. There's another
Give
And
us
I
a-
just see
give
like
us
the
a what?
expansibility.
Give us a 5-0 Shockwave, guys.
Yeah.
So I decided now based on this to use a Shockwave. So I'm going to go ahead and use a Shockwave 5-0. And so now we're going to go ahead and Shockwave this, and then we'll decide on terms of stent sizing. So again, hopefully by 9:30 we'll be done with this case. Oh, so we've got our IVUS guru there. So can you show me the bookmarked area?
Yeah.
What was the size? Shockwave 5.
IVUS gurus, we're over here.
Brahman is like, the eyes are here. What are you looking at? Wow.
Yeah, it's about 4.8. So
About
Roman,
the area.
you guys
And
were
this is
off
at
by
the-
0.2.
This is
No, the diameter, the area is 4.8.
I don't think he measured it right.
That's true. You have to go.
He
up
missed
a
a spot. He missed a spot at 8 o'clock. So that's our point too.
So what we've decided to do now is Shockwave this area, and then the question is whether we put a Supera, 5-0 Supera, into this after a DCB is the question, or do we use a drug-eluting stent? I like a Supera here if we get a good expansion. If we get good expansion, let's see whether we get a 5-0 Supera. Okay. I would still like to balloon with a 6-0 balloon if we're going to put a 5-0 Supera in this very difficult lesion.
Yeah.
For a 5-5 Supera, but let's see.
Hold on.
So we're gonna now get this together. So talk to me, guys, in terms of would you leave it with just a DCB?
Oof.
So
I mean, if I would not leave it with the DCB because at this point of time, I mean, we clearly know. I know we are central luminal, but we created this is a dissection plane. So I don't think it's with the amount of plaque there is and calcification there is, the recoil is going to be very, very high. So I don't know if the PTA is going to give you such a high, such a good result. At some point, we'll have to stent it, and I think the 80 is a very robust 80, like 4-0 vessel. So, any thoughts?
I mean, I don't disagree. I mean, I think one could make the argument that if we do Shockwave and we've disrupted this calcium well, and the DCB has a good expansion, and there's no significant recoil we see at that level, that perhaps the only stenting that will have to happen will be at the ostium of the AT into the popliteal, and we could spare the popliteal a dedicated Supera stent. But I just think that I don't foresee that being the case here. I think we're going to see a good amount of recoil.
Can you go back on the IVUS a little bit?
Yeah, we'll
play the IVUS again,
go up.
Go up on the IVUS a little bit for him.
Roll it up. Yeah, come down.
Yeah.
Come down on the roller.
Come down on the roller.
So I guess the biggest thing is how many
down on the
dissection
roller.
planes we have and the
More. In the mid pop, keep coming down. Keep coming down.
Pop, keep coming.
Keep coming. Coming. So stop here.
Stop.
So this is your mid pop. right, PK? So there is no shadowing. The shadowing is extremely minimal. So this is all plaque. There is no calcification in the mid pop.
I know, but remember,
so
it all
with this
depends.
plaque, unless my suggestion, my thought process is, this is not going to disrupt with. This is not going to get any better with Shockwave. Shockwave is not going to do anything here. We are doing it more for the proximal and more for the distal. The mid is just still going to recoil. Unless you want to atherectomize this aggressively, then it's a different story.
Yeah. Well, I guess the biggest concern, like you said, is multiple entry planes and a flap. So for me, leaving it, however good the PTA might be, the recoil, and after 10 minutes of shutdown, you follow it up. The recoil is pretty high.
Yeah, we're going to go up to 2 atmospheres.
So that'll be pretty much like a true justice to the patient.
Shockwave,
this is a 5 Shockwave?
Yeah.
So PK, correct me if I'm wrong. If the impact data of the 5 years, the failure of the DCB doesn't depend on the dissection or anything. It depends on the recoil rates, right?
Yeah, it's 30%. That's our data. Our data. We're just publishing now. It's actually been accepted. It'll be out soon in manuscript form. That data will shows, at least in the impact group of data of both the impact IDE study as well as impact Japan and the impact global cohort of imaging, that dissection plane did not have a role in stenting. However, as you see, it does not have a role in failure. I would go up again to 4 and then go up one more time with those Shockwave. So therefore, it's recall greater than 30%.
Right,
so that's where vessel prep really comes in very importantly. And I think here, it may, I shouldn't say it does. I know Medtronic would like to say it does, but we don't know. The idea would be here, well, what can we do for vessel prep? So here Luke is going up with a 5.0 Shockwave balloon. She's having a little bit of pain. But at the same time, what we're going to do is we're going to be able to at least prepare this vessel properly to accept the DCB and then take a look. The idea of whether a stent is needed or not is unknown because obviously the role of stents in these long lesions of impact global are not known because they're about 40% of those long lesions were stented. So let's go up here.
Right there.
So if you see that mid area where we ballooned, PK, the mid pop expanded very nicely. So I think that's because it's all that plaque.
So you can see here again. Here,
25, 26 is the real lesion.
That's the real calcified lesion. I think it was wise to go with Shockwave here. So we're going to go ahead and do this with the Shockwave balloon and then decide. So here the Shockwave is going up, as you can see here.
My most concern is not this calcification because this we can expand with the Shockwave and give a DCB. My concern is that mid pop where all the plaque is. That's where I think is the most recoil going to happen if you leave it without a metal platform. The distal and the proximal is okay.
We're going to go up to 4 here. We're going to go up again. I mean, I think that's expanded quite well. I mean, let's see. We'll take a look. We'll get a feel for it, and then we'll decide.
See, now it's expanded better.
4 atmospheres now, and then go up again.
No, you're right, Karthik. I mean, the plaque itself. But remember, with plaque morphology, if you do good atherectomy and DCB.
Yeah, that's what I'm saying.
Hopefully the patency rate should not be.
PK, would you go back in with the EXL and do this plaqued area with?
I don't know whether we're going to really achieve a bigger lumen with an EXL. It's an undersized atherectomy device here. So I think what we do is, what we're doing here is pretty good. If anything, now that I've expanded it with Shockwave, we'll go with a larger balloon and blast it. And then take a look. But let's first go slowly.
Just expanded. Nice.
Yeah, just expanded nicely there. Go to 8 here, Luke, just to get a really good.
Yeah, so see, like we use a 3.0 balloon to begin with. This is the first using a 5.0. So maybe using a 5.0 DCB long would probably give us good results.
Deliver with higher atmosphere pressure.
Right.
Just try to get that area fully expanded.
We can actually bring up a little bit more because the middle emitters.
So the proximal AT, you would leave that too?
PP, okay.
Vishal and PK, would you still leave that proximal AT alone, or would you stent that proximal AT?
I don't know how it looks. I mean, like you said, if the proximal AT doesn't, if you're stenting the pop, then I would probably want to maintain my continuity into the proximal AT if it looks okay. If you really want to plaque modify it, here you could use a short serenator right there. If you want to avoid stenting it, I would probably do the serenator part of it.
I would not do a serenator.
At the AT.
It's just expensive.
It's an expense, but we're talking about AT. Popliteal, I 100% agree with PK. There's no reason.
I'd much rather stent it than do a serenator.
Okay, good.
Okay, let it go up now. You guys,
Case
the
dismissed.
data with UConn, Achilles,
Right.
Destiny.
Correct.
I mean, with these
Yep.
stents are phenomenal.
It's
I mean,
this
no, I
phenomenon.
agree.
Yeah,
you know,
92%.
so I think it's better
It's a
to just
patency
stent
rates.
it. I mean,
No, I
as long
agree.
as you can
Agree
expand
with
it,
that.
I think
No-
you just go ahead and
Right.
stent
No
it.
real
That's what I think.
fracture rate, good patency rate. Yeah, I mean, you should definitely use them.
Very nice. I like that
But the
expansion.
expansion is good.
Beautiful.
And we're going at just 4 and then to 6 here. Not
I
going
think he
Yeah.
went
straight
up to
to
8.
I went to
and
6.
10 also.
8. Yeah, okay.
Yeah, I think he's just
No, I just
expanding.
wanted to expand it.
Yeah.
We
Hey,
want to
Donald's
work it as
walking
a
into the
pure
SFA,
plain
he's
old
got
balloon
the
as
report.
well. So we did the 8.
Just walking into the process. Okay.
Yeah.
Okay, guys, DSA here, quick. We're just gonna
Yeah.
leave it there. Okay, no mueva.
That's very nice.
Mm-hmm.
Yeah, that's
So
much better.
Yep.
What's the matter? PP?
now the plan.
For the wire.
Oh, Mars, we're back.
Inject. Okay.
Very
everything
nice.
Here looks good.
Yeah,
Okay.
Beautiful.
So now we just get the question is what are you going to do here? Let's take a minus here. Let's push this wire down a
Yeah.
little bit.
Hold on.
Go take a piss. It's fine. Okay.
Yeah, where-
Yeah.
Okay, here.
Yeah. PK, you're still going to use that Shockwave for that ostial SFA, right? I'm
We
assuming.
might
Yeah, we
decide to. I
Yeah,
mean,
yeah.
right now, I mean, look, we've expanded everything. There's really no dissection distally. The
Agreed.
dissection is really in the flop. I think you got to send that 18 now.
Correct.
So give me a 4-0 long DES, please. Or
No,
a
so what are you
4-5.
planning to do with the popliteal? If you
I
want to
mean,
do
right
that.
now, I think you got to take care of the outflow. So I think you have a dissection at the level above 5, so 5-4-3. You got to take care of all that. So either. I mean, I don't think a superior is going to work because you're going to have a
Correct.
tremendous
So we can do
mismatch.
the DS.
So we can do a 4-4-4-4-4-5.
We can do a Megatron.
4 or 5 Megatron and then balloon it into a 5 up
5,
top.
5. Yeah.
And then go ahead and deploy the superior if
DS,
needed.
yeah.
You don't need it,
DCB,
but
the
I'd rather
DCB,
do a
the pop.
DCB.
I agree, I
think
agree.
that's it.
That's a good
Check
strategy.
this out, guys.
Okay, we're to put the wire down.
Nice
The
strategy.
wire's down. I mean, no. First,
corner,
Megatron 4-4-0. 4-0 long. Whatever the long coronary DS you have.
Yeah, a 48 maybe.
Yeah, so those the synergies come in the 48. There's now the Zions also has a 4.5 and 5.0s,
Yeah.
but in our lab as of right now, we just have them coming up to 28 millimeters.
Yeah, the Megatron is
did-
good.
if
It's
you did
like,
want to go
because you
with
can
those.
make it up to 5.5.
So now we're just going to go ahead and stent this and then DCB it. Take a picture, and I think if it's all done, we're going to call it a day and just work the rest of it offline.
You can leave it,
which is-
Vishal. I don't think you need much wire support here.
I'm sorry.
No, I'm not
wait,
leaving. It's
but-
just so stiff. I don't want to kink it, so I'm going slow. It's very stiff, the balloon. Look.
I'm saying you
I'm
can
going
just
small
leave it
bites.
there where it is.
No, I'm not trying to push the wire. See how my wire comes back? It's the balloon is stiff. Don't pull, PK, don't pull. Please don't pull. I'm taking
Piggy,
it's
just
very
just
stiff
to
balloon.
clarify, were you saying that you would stent
wanna
the
kink my
18
wire.
to the distal pop and then DCB the pop, and Piggy, you were saying you wouldn't supera it if it looked
I mean,
fine?
I think you could. I think you could. I mean,
Uh-huh.
I really think you could. I mean, it's just a question of how it looks after we put the
DCB.
the DCB. Yeah,
Mm-hmm.
I'm going to go with the 6.0 DCB.
Wow.
I mean, half sizes are available now. Did we get the half sizes of the 018 Medtronic yet
Hold
or
on.
no? Uh-huh.
1 second.
What seems to be going on?
No, it's just a very
being delicate. It's
stiff.
very.
What? No,
It's just very
it is,
stiff.
it's
yeah.
a very stiff balloon.
Very
So
stiff,
I don't want to kink my wire.
Vishal likes
And
to
it's
be
very
delicate,
stiff.
so it's okay. Vishal, take your time.
No, I'm serious note. It is very stiff. It's
It
a
is.
barely
I know,
pull it back.
I know.
Is he getting stuck
And
in
pull
that
back more.
in that ostial SFA lesion?
I don't know. We are still negative on the indiflator, so it's not.
Let me see.
No, I'm sure.
Yeah, the wire's stuck in the vessel. Okay. It's not going to come. Advance it. See if it advances.
Advance the balloon.
Fantastic. Yeah. Advance the balloon. Go.
It's probably stuck to the wire. The balloon is stuck to the
Yeah,
wire.
that's
probably.
something stuck to the wire.
I'm going to change the wire.
Yeah,
Advance
that's
it all the way down.
It's stuck to the wire.
That's interesting.
It does. Like sometimes the wire gets very dry and gets stuck to the balloon itself.
No.
Is it going?
Where is it? Do you see it? I don't
No,
see.
it's not there yet.
It's there.
Yeah,
Keep going. Keep going.
yeah.
Keep going. Keep going. Keep going. Keep going. Okay, let's balloon. That's good. Right there. That's good. No, just pull the wire out. Okay. Give us a new wire, guys. A new wet one. Give me a wet wire. Give me a wet one here. So again, long cases, long things happen.
Yeah.
Just have to deal with it.
Now, things that some people do is you can use Rotoglide to really get the wire very well lubricated. If you do find something like that, attach a co-pilot, put it over, inject some of the Rotoglide over the back of the wire to help facilitate some lubrication between the hypotubing and the wire itself. But then you have to make Rotoglide.
There's definitely something going on here.
Oh, it's probably the balloon itself.
No, but the wire should be maybe you pull back. Yeah.
I am pulling the balloon back a little.
Yeah, maybe if hopefully it's not buckled somewhere. It shouldn't be, but.
Oh, it's fine. Just don't worry, we'll get there.
Yeah, we'll get there.
It's fine. It's an open lumen.
So yeah, we ballooned it. Yeah.
I don't see any reason why we should have any difficulties.
Take a command now.
Did we make a tip on this wire? No. There it goes.
It okay. Beautiful. It's open lumen.
Okay, good.
Okay, let me see the tip for you. Okay, good.
Okay, a little slow.
Probably the catheter kinked somewhere. So that's probably
yeah, that's something. The balloon probably just because we were pushing, probably just kinked somewhere in the.
Okay, we're out. All right, sorry about the delay. Let's give us a Megatron now.
And then we can take a 5.0 balloon.
Just for our viewers, we have, we're coming up on about an hour and a half. We're almost, we're going to finish up most of this case right now, and then we still have to discuss how we're going to treat that ostial SFA. So PK.
What do you think, VK? How do you do the ostial SFA? Even though we're gonna continue recording while VK and Luke finish that up, while I go and do some other things like other procedures that are waiting. But what we're gonna do is we're gonna go ahead and record it. But VK and Luke, why don't you guys tell them what you'll be doing?
So the same thing. I will probably use a Shockwave up there because it's the non-stented portion, which looks calcified and eccentric. And then probably do a DCB and try to salvage it. Don't want to stent across.
Let's go inject.
Yeah, maybe pull back a little bit. Let's see.
I don't know. What would you like to do, Luke?
Yeah, I think Shockwave DCB is a reasonable.
Is that good, or you want to go back?
Yeah, too much in, right?
Too much in. Come back.
After that, probably just right before that collateral. PK. What do you think?
Okay, I like that. So Shockwave DCB is what Luke is saying.
Yeah, I think I agree with that. Pull back a little bit more.
Yeah, it's pretty good.
I think it's
like
a spasm more than
Shockwave idea, but
I think that's good.
Probably
Let's go up here
with the silver.
Yeah, I like this.
PK, you want to go across that collateral?
Yeah, definitely. It'll be fine. It'll be fine.
PK, you want to go and like it's 12. Yeah, I'm gone.
Okay, down and go up again.
Yeah.
You can pull back a little bit and go up again.
Yeah, we will. We're just going to go up twice here.
It's a
4.0 down. I'm going to pull back a little and just not blast it up here.
Yeah. Go crazy.
Okay.
It's coming.
Yeah, that's it. Go crazy.
And then we can do a DCB up top. 24.
Okay, down.
I know.
Okay. Hopefully it didn't burp. Let's see.
22.
I think so. I mean, you used a 5.0.
This is a 4 or 5?
This is a 4. No, I'm saying he used a 5.0 Shockwave, so it didn't perf then.
Yeah, I know.
There's no reason for it to perf now.
And the collateral remains.
Beautiful.
Yeah.
All right, good. So now we're going to go ahead
5.0
and we're going to sign off here. I mean, we'll do the DCB. Actually, give us a 5.0 long DCB, guys. 5.0 what length? 150?
Yeah,
5.0 150, guys. So we'll do a 5.0.
Nice result.
Yeah. Maybe we can also, in the meantime, just go back to the cine of that, or the DSA of that ostial SFA, so we can just talk online about what exactly will be the definitive therapy for that lesion.
Vishal, what are you going to put the patient on? Medical therapy.
Well, first let's talk about this.
Yeah, let's go.
Yeah, let's go with this. All right, what do you want to do? Why do you guys want to shockwave this? It's ISR.
Well, no, the
ostium doesn't come. It doesn't come until the ostium.
Correct.
So you think there's calcium there?
Yeah.
Okay.
So.
All right, if there's calcium, then that's different. Okay.
It's the non-stented.
So we have the 5.0 Shockwave. We've got a couple of more cycles left of life in it, and then we'll go ahead and take a look. Ray, you want to go to room 4, see what's going on? And then what I'll do is I will
short DCB.
And we will start here.
Okay.
I actually did not realize there was already a stent in there. So
Yeah.
Yeah, but
take
like you said, the
back what I
lesion is
originally
before the
said.
stent.
I go back. Yeah, so your options are either just do a DCB through and through from the ostium of that SFA to pass a stent, because there's a little bit of some disease
Rail
that
Vishal?
stent too.
1 second.
Isn't that railing?
No, hold on.
Or I mean,
Okay,
this is somebody who has proven ISR, has lots of revascularization issues and needing to come back again and again. I think DCB is probably the safest, and if
We
she
can put
comes back
a
next
O3,
time, you could do
go where
a
it's
diluting stent,
Agreed.
and then
Okay.
if
Nice
it
rail.
fails again, then
You're not
have all
going to rail.
our other options.
No. Give us an 035 Spartaco
Yeah.
Supercore. Take it out. Here we go.
Yeah, it's
Yeah,
easy.
That's the best
Just
way
Yeah,
to
put
go.
this, this
Some disease.
Medtronic balloon is very difficult to track. Thank God they're finally getting
Coming
a
up with an 018.
018 system
Yeah.
that's working, and it's going to be coming out very, very soon. I've been told. I'm excited for them. They're actually leaving the dark ages and coming to the light ages, and so it's wonderful.
I think they are the only, or even
BD already has it. Everybody.
yeah, I
already
know BD has
it.
it, Ranger
Yeah.
has it, so
Ranger has it, so I think Medtronic doing that is finally wonderful. I really do. They have
Stellar X is still 035, right?
You know what? I'm not aware. I'm gonna have to talk to the Philips people to find out. Hold on, just take this down slowly.
Yeah.
Just rail it for me.
That's the plane.
Let go now. Just let go for it. Let go. Okay. Now give us a little. Give us not a die. I just need a.
Yeah.
Now this is the
Direction.
plane. That's the problem. We're in some sort of plane now.
Yeah, that's what.
Okay. All right. Give me a better wire than this, guys. Give me a woolly wire or something, or give me a. Yeah, this is the issue. We need a torqueable wire, maybe a Terumo glide wire, 035 angle.
Yeah, we have that.
Or use an 018 Terumo Gold if you have it already.
No, it's not going to be able to track.
No, it won't track.
This is like I told you, this is a bus. So this is a very difficult one. It's only a 5.0.
Yeah, look at it, 6.0.
Imagine the 250s. It's a bus. Listen, I mean, these. I think Medtronic does a lot of things well, but they're really slow on this one, and they finally are able to get it done, which I'm very, very happy for. I think they've got their data is definitely best in class right now. They have the most data available out there that tells us in terms of what is happening with their DCB. They've been sponsoring the majority of the trials and the studies. They're unabashed about publishing their data, which I think is, incredibly important in our field, as you guys both know, and all three of you know. So you can see how difficult this is. This is not a joke. I mean, this is. Let me look at my sheet now. I mean, this is really not fun. The sheet is probably somewhere up in the aorta.
No, it's still
quite
there, which is
Let
good.
me just push the sheet down a little bit to there. You don't need to struggle like this. Is my point.
Yeah.
You don't need to struggle. I mean, if you look at the coronary guys, they're doing all the cool stuff with all the nice things and easily trackable. In peripheral, this should not be the case. There you go. Okay, good. Let's go up now. So anyway, like I was saying, I applaud them for a lot of things, and I applaud them for actually bringing out the 035, the 018 DCB, because now the balloon it works great. We have 5-year data. We have data looking at failures of DCB. So I think this is just going to allow us to give the best-in-class data with excellent deliverability, which is what we need.
Yeah, because DCBs are not used for expanding the balloon anyway, and expanding the lesions, right? They're used for more deliverability of the drug.
Exactly.
So
but the problem is if you can't deliver
018, 014, it doesn't really matter. If with 035s, if you cannot deliver, then
and the whole point is added step of needing to change out your wire. I mean, it'd be obviously we have very skilled operators here, but like that could pose a serious problem, pulling out the balloon and exchanging the wire after you've dissected through it. And then you may have to restart entirely. You know, like PK is, he went to the perfect next wire, which is with that 035 glide wire to help, kind of puncture through. And it's a very it's a challenging situation to have to go through. And if you choose to do it, diligently, and as all operators should, who are not as experienced as PK, to pull the wire back, to take the balloon out, and then change out the wire for the 035. I mean, it's just time.
It's time, and we're already an hour and a half into this case, and it's equipment, radiation, and if you want.
I mean, it tires the operator, so that's the point. So it's like, and your hands get tired, and
for the next 12 cases.
Okay, hang on, sweetheart. So now we're going for 2 minutes.
Right.
And then we'll take a nice picture. I don't know if that's a bubble or didn't expand. I don't know.
No, I think it's just a bubble.
It's just a bubble, I think.
It's just a bubble.
Yeah, because the rest of it is pretty well expanded.
Correct.
Doesn't look like any 30% recoil anywhere. I just want to go to different views.
No.
At least, it looks pretty good to us. So I think that clearly is a bubble.
Yeah. But you remember the previous Shockwave did expand well there, so there's no reason.
Vishal, what anticoagulation are you planning to use?
So I'm going to put on aspirin, Plavix, and I'm going to, in her case, because of the extensive disease, I'm going to put on a rivaroxaban 2.5 twice a daily. That's the goal.
So triple therapy or?
Okay, 2 minutes. Give us an 035 wire, please.
She's
give us a supercore now.
Yeah. She's a vascular path, as you can see, with so much disease everywhere.
So one of the things for everybody at home, like, this is an extra step, but it's actually worth it because it reduces your complications of wire perf or anything like that as you're pulling this back. Yeah. So change out for a supercore, a safer wire. If you want to deliver your nipride through this, let's deliver our nipride through this.
Sure.
Give us a little nipride.
So, PK, I know Vishal is using triple therapy, but PK and Raman, what do you guys think? You guys are still using triple therapy or?
Just depends on this nitro. No, there's nothing.
I kind of save the triple therapy for people who I think have a high thrombotic burden. And that too, even in those cases, I'll consider. Consider again, the clinical context is different from patient to patient to put them on actual anticoagulation doses. But for her, I think even just aspirin Xarelto may be sufficient.
That's it. It's gonna go.
I'm not sure whether I'll put her on Plavix as well.
It's gonna.
PK, you're still using it on all patients, PK, triple therapy? Or?
Yeah, no, I mean, we rarely use triple therapy. I mean, I think you see I think the reason to do this is the data is so strong in terms of reduction in vascular events and cardiovascular events.
Correct.
Everything else I think is very iffy for us. Triple therapy definitely increases the risk of bleeding, and I think you have to know your bleeding score of the patients and really understand where you're going to do it. So generally speaking, Luke can attest to this. We rarely go with triple therapy. We always go with dual therapy, and whether it's a dual antiplatelet or whether it's with rivaroxaban and So I think in this case, if our bleeding risk is low, I don't know what benefit you're going to get out of triple therapy. So I think that you just have to be very, very careful here. You have a little mid dissection there. So the question is, dissection didn't play out, but again, this lesion wasn't exactly studied in any DCB trial. So the question will be whether you want to stent it or not. And I'll leave that to Vishal's discretion. You can see the flow is beautiful. Little spasm at the site, but I don't think I'm worried about that. The only issue is this area here. And I think with that, Vishal, what are you planning on doing? We'll tell the audience. Let's take another view just to make sure how it looks. And then
pull the wire and see?
No, I don't want to pull it yet. I mean, we can if you want. Yeah, we can do it next. Yeah, it's a pretty bad dissection.
Yeah, we might have to do a supera. Right
now. So Vishal, you want to do a supera? Yeah. You want to do a Zilver? I mean, what's your choice? Well, you already DCB'd it, right?
Correct.
So,
I think supera should work.
All right, so we're gonna go ahead and deliver a supera there. We're gonna do what size supera are you gonna use?
I think a 5.0 should suffice.
So we're gonna do a 5.0 supera, and then the ostium you guys are gonna do Shockwave and DCB.
Shockwave and DCB and up.
Yeah. Okay, so with that, for our AV team, we're gonna continue recording this till the end. For us, we'll sign off here. I know you guys got to get to work. Vishal and Luke will finish this off while we go take care of the other cases, and we'll see you guys on in the 20th of July for our next live case. And Luke, thank you so much for a wonderful year with us. It was really a pleasure to have you with us.
Thanks so much.
And Twinkle, wherever you are, congratulations. Very good job.
Twinkle, good luck.
And we will see you guys in July. Thank you. Thank you guys so much.
Thank
Yeah,
you.
wonderful case. Great
Thank you
job.
guys very much. And we look forward to welcoming you guys back again on July 20th for our next live peripheral broadcast for our CCC live cases here from Mount Sinai. And thank you very much and have a great day.